Hello, good morning, everyone. Welcome today to our continuous education NICU. Today we have our presentation by Dr. Hayam as a case of case discussion. It is actually our case in intensive care unit. So, Dr. Hayam, the floor is yours. شكرا جزيلا.
Okay. السلام عليكم.
وعليكم السلام دكتور، اتفضلي يعني.
Good morning, everyone. I can start, Asma?
Yes, doctor, you have the control. Doctor, can you move the slide?
We can see the presentation here. It's okay, yes. Can you speak? I'm not hearing you.
The presentation.
احنا شايفين presentation.
No, I think you have to share.
Hello, doctor. Hello.
أيوة أسمع.
يس لا
معايا؟
دكتور محمد أبشر معي بالخط الثاني. دكتورة هيام معي.
طيب you can hear me؟ لا هنا جنبي مش سامعين.
سامعينك يا هيام والله. جو اون يا هيام. We are listening to you.
You can hear me? You can see
Yes
my
يا هيام.
slides? I can start?
Yes يا هيام. Yes دكتورة هيام. Please start. هيام.
Okay, fine. Assalamu alaikum. Today I'm going to present an interesting scenario actually for one of our babies in ICU, and the name is SOPH Syndrome. Maybe this is the first time for the attendee to hear about it, and for me as well. It was a challenging case, and to get your attention, I'm just thinking to share with you some of the ideas. I remember my daughter, she was always asking me, Mama, why you are reading all the time? And I told her the real challenge when you face a case written in the textbook in 2 lines as a human being, and he need a workup, and he need a diagnosis, and he need a prognosis, and the family have a question to answer. So even if no one hear about the SOPH syndrome before, and maybe they will never hear it again, it is interesting to know because it is the question to be answered and mystery to be solved. So baby of SA will use this first letters for the privacy because the baby is still in the NICU. He was born as a late preterm, 35-weeker, severe IUGR with birth weight was 1 kg 65 gram to a mother, which is a known case of SLE on medication. So according to the gross chart at birth, the baby had this severe symmetrical IUGR, subtle dysmorphic features. In tiny baby, sometimes early it's difficult to assess the dysmorphic feature unless it is evident. So we consider it subtle dysmorphic features. He had the bilateral talibus equivarus, and he had mild RDS, required CPAP shortly for a few hours as on day 1 of life. So maternal history, the mother, she was booked case. She was booked actually in EHS, and she was booked also in private. She was 33 years old. Sorry. Gravida 3 para 2 with 2 healthy siblings. She's a known case of SLE. She was diagnosed in 2018, and she's on hydroxychloroquine. Her serology was negative. There was nothing significant in the history other than this. Early scan was missed actually, and the anomaly scan, the first one, was done at the age of 23 weeks plus 6 days, showing growth discrepancy and normal Liker, and bilateral prominent renal pelvis and right club foot. Scan was repeated at the age of 33 weeks plus 1 day, showing severe IUGR with normal Doppler, abnormal head shape, which was not specified at that time, cerebellar looks abnormal, and the cisterna magna was obliterated. Baby was born with elective cesarean section due to severe IUGR and abnormal Doppler, and after admission she had pathological CTG. For that they went for emergency section. Baby born with good Apgar score. Actually, work of breathing was a little bit increased. That's why he required CPAP for a few hours only during day 1. We are thinking about the family history. We take it in details after a while. The parents are first degree cousin. They have 2 healthy siblings. They conceive spontaneously. Antenatally, in private, the mother, she did NIPT at the 18 weeks plus 1 day. There was low risk for non-trisomy, trisomy 13, 21, and 18. Low risk also for rare autosomal aneuploidies like trisomy 9, 16, and 22. Baby sex was determined as a female, and also 6 chromosomal aneuploidy like mono XXO, X0, double X. This is also not detected. The mother was counseled for amniocentesis or chronic villus sampling, and she declined that. She continued follow-up with our obstetrician till the age of 33 weeks. Again, repeated scan once more. Severe IUGR with normal Doppler, and the baby was born at the 35 weeks as a late preterm. this is the first look on the growth chart, because this is the cornerstone actually of the of starting the journey of diagnosis for this baby. Had the severe IUGR with head circumference below, and as you see, it's not growing.
Hayam, I think the
Baby
slide
is
is not
almost
moving.
5 months old
Hayam.
now, and this is
Hayam.
the growth chart for the weight. So he's always below the 0.3 even centile for weight and head circumference.
Yeah, Dr. Hayam. Yeah, Hayam, the slide is not moving.
So actually, this baby course was, we can tell, very stormy. What's the first thing that required our attention? The baby had thrombocytopenia, which is explained for IUGR mother. IUGR and had thrombocytopenia and failure to growth, and also facing difficulty in swallowing. With the time, this subtle dysmorphic feature was evident. So we did like a scanning at a time, as according to our protocol. Brain ultrasound was done at birth, showing periventricular echogenicity and flaring. We did it follow up at the age of 3 weeks. Later on, the echogenicity was increased with some cortical and subcortical bilaterally. Suspected.
السلايد بتاعتي مش بتتحرك.
والله؟
محمد.
You can see my slides now.
We can see the slides, Hayam. سمعاني؟ الو هيام، انت سمعاني؟
احنا سامعينك يا احمد، بس I don't know why Hayam is not listening.
I think the connection is. I will call Asma to take the control. ايوه يا احمد، صباح الخير.
Okay, Dr. Hayam, which slide you are in?
Assalamu alaikum again. Sorry for this disturbance. It's, I think, technical issue. Yes. Anyway, you can see my slides now. So this is the problem list which the baby admitted with. This is very short. Logic, IUGR for SLE mother, no family history of significance, mild RDS, late preterm. It was like initially, it was fine. Next, Asma, please. So the maternal history, we discussed it. There is nothing of interest rather than the antenatal scanning, which shows severe IUGR and the bilateral hydronephrosis and bilateral talibus equinovarus, and query abnormal head shape and obliterated cisterna magna. Next. As we mentioned, that the family history is not significant also, the first degree cousin, and they have 2 healthy siblings and no previous abortion or stillbirth or neonatal death. Next. We discussed this gross chart, head circumference, very below the 0.3 centile for weight and head circumference. Next. Next. Yeah, we'll go by systemic review for baby of SA. Initial brain ultrasound done at birth, which is showing periventricular echogenicity and flaring. In the follow-up, also it was increasing with some cortical and subcortical region of increased echogenicity, suspected hypoxia. We mentioned that the Apgar score was okay. At the age of 1 month, there was showing like mild progression, dilatation of the ventricular system. So we confirmed that by brain CT at the age of 2 months. Show bilateral parieto-occipital feature of chronic ischemic changes, which was not explained because the baby at that time he was room air most of the time. He need best only support for a few days, and Apgar score was fine. And the only thing in the history is pathological CTG at the time of delivery. So there was also some ischemic atrophic changes with the increase in the secondary exaggerated extraaxial space for the CSF. Mild also supra and infratentorial hydrocephalus. So we planned for MRI to confirm that. MRI brain actually showing the same finding, few sporadic intraparenchymal and subarachnoid foci of petechial hemorrhage, thin corpus callosum, narrowing and kinking of the cranio-cervical junction and the upper cervical cord. And we will find this one of the criteria of this syndrome actually to have like skeletal anomalies, including cranio-cervical junction and cervical vertebrate. Baby clinically was hypoactive. He's not interested in sucking. All the time sleeping. There was the discussion about the tones because the baby had contracture actually in the lower limb. And for that, we did CK and we confirmed it by EMG and nerve conduction study, and it was going with myopathy. And with this finding discussed with neurosurgery and neurophysiology, we advised to repeat it later on for confirmation. Next. As a baby born as a 35-weeker, we did eye examination and fundoscopy at the age of 4 weeks of life as per our local protocol. And the finding was a little bit interesting also, and all the ophthalmology team discussed the case together, and they put a differential diagnosis of Rush disease, which is an aggressive form of ROP, or familial exudative vitreoretinopathy. There was a retinal bleeding, and the plan for Avastin injection and follow-up examination. So the baby underwent for Avastin injection and follow-up by ophthalmology team. And later on, it shows like mild disc pallor and area of atrophic changes. It happens. So now we have skeletal anomalies, restricted in utero, يعني antenatal intrauterine growth restriction and postnatal growth restriction. We have skeletal anomaly. We have interesting finding. This Rush disease and familial exudative vitreoretinopathy is a very rare disease, and it was progressing to optic atrophy. Next. Respiratory system. Initially, the baby had like mild form of RDS, required CPAP for a while, a few hours, maybe next day was room air. The baby was room air for a while, for maybe 1 month actually. But whenever during his clinical course, he's having on and off respiratory distress, to confirm by X-ray, right upper lobe collapse. Because of that, actually, the baby required the CPAP, which upgraded to biphasic CPAP, and this is at the age of 1 month. And at that time, the baby he had the septic shock, required intubation at the age of 5 weeks. And since then, we are almost all the time intubated. We extubate him, and then he will crash, and then re-intubation. re-intubated, and currently the baby on NIPPV, non-invasive ventilation. Next. Cardiovascular, because of the mother having SLE, it was of course one of the basic workup to do ECG to rule out heart block, and it was ruled out already. ECG was normal, no heart block, and QTC was normal. Echo antenatally, there was echogenic foci, and they were suspected anomalies, but antenatally the first one was a little bit not conclusive. There was open PFO, small BDA. There was doubt about the pulmonary venous return, which is confirmed to be normal later on. The follow-up echo was almost normal, and the BDA and PFO was closed. Next. GIT and metabolic, the baby, because of the severe IUGR, he was started on TPN, and 35 weeks, you expect him to start feeding early, but the issue when you are not expecting the baby to reach full feed within 5 days, or he's below 1.5, we are starting TPN for nutritional purposes. And we were building up the feed, but unfortunately, the baby was not sucking successfully. We did, of course, abdominal ultrasound and QB showing biliary sludge, and baby went into neonatal cholestasis at a point. QB showing a prominent pelvic calyceal system dilatation on the left side mainly. And we faced difficulty in the feeding all the time. For that, we consulted the speech therapist, and she was following with him. And the issue of hypotonia was still raised, but not solved yet. Next. We did CK to confirm about the possibility of myopathy, which was normal. Skeletal survey show only bilateral club foot or congenital talipes equivalence. Hip ultrasound show mild left-sided lateral hip subluxation. Knee ultrasound done actually because during his course the baby had like a picture of knee effusion and ankle effusion. For that, he was investigated radiologically by ultrasound and MRI, and it was also showing a picture of effusion and enhancement of soft tissue around, and the possibility of MRI, for septic arthritis was raised because the baby had like a recurrent infection, and with positive culture and even without positive culture, and like a clinical sepsis. And he was receiving multiple courses of antibiotic. Next. Because of this morphism, yes, the features was showing small triangular face. When you look at the baby, you remember the progeria face. It looks like senile face, prominent eyes, smooth and long plethora, pointed chin, thin upper limb, single crease in the left hand, knee contracture, bilateral talibus, dry skin, pectus excavatum, cloudy cornea initially, which was not resolved later on. We send microarray at the age of 11 days of life, and actually it takes time to be released. And after waiting for a long time, it came to be normal. And still, we don't have a diagnosis for this baby. And we decided to send the whole exome sequence at the age of 6 weeks after the microarray was reported normal. And that was the key. We'll come to that later on. Next. Next. Regarding infectious disease and hematology, the baby initially had thrombocytopenia, which was resolved. He had his first attack of clinical sepsis at the age of 3 days at the site of PICC line insertion, picture of thrombophlebitis. We did torch, of course, as part of his workup, which he reported negative. He had recurrent clinical sepsis with increased inflammatory markers, required multiple courses of antibiotic. Can we go back one slide, Ms. Asma, please? Again, one more. Baby had the septic shock during his hospital stay with Klebsiella pneumonia and Enterococcus fecalis. He had urosepsis more than once, one with Klebsiella and one with E. coli, multi-drug resistant. And they also, we mentioned that they had like joint effusion, and we were thinking about septic arthritis and the osteomyelitis. This was ruled out. But recurrent infection with very high inflammatory markers also raised the possibility of immunodeficiency. And CMV also was sent because of recurrent persistent thrombocytopenia and hepatosplenomegaly, raised the possibility of CMV, and already it was positive, and baby started on acyclovir. Next. Immunology team actually was consulted initially, and we did the workup for that. We sent for anti-nuclear antibody, became positive, double-stranded DNA positive, anti-Rho, anti-La positive, and we sent also for immunoglobulin level as total and differential, and we sent also for subtypes of lymphocytes, which confirm the diagnosis of primary immune deficiency and hypogammaglobulinemia, and baby was receiving immunoglobulins for that. Next. As you see, this baby actually, all the system was hit, and we used our resources, and we used all our subspecialty teams, starting from cardiology, immunology, orthopedics, ophthalmology, endocrinology, because he finally also he had a recurrent hyperglycemia, required insulin at a time. Genetic team, speech therapy for swallowing study and for poor feeding, infectious disease due to recurrent infection, nephrology because of bilateral hydronephrosis, and he developed nephrocalcinosis in between, and also recurrent UTI, and neurophysiology. I wish I didn't miss any of the subspecialty because all of them were involved in this case. Next. So this is the problem list for baby of SA at the time of admission. Still, we don't know what's going on. Microarray is normal, and still the mystery is not solved. And I will share with you now the problem list after his hospital stay, because next, Asma, please. You can compare now the problem list. I try even to modify and remove many of acute things that was already solved. So neonatal lupus was hypogammaglobulinemia with primary immunodeficiency, neonatal myopathy, hydronephrosis, rush disease, septic shock, CMV, hyperglycemia, and still under investigation for neonatal diabetes. Acute kidney injury, right upper loop collapse, left knee swelling, nephrocalcinosis. At the time, even with the baby was intubated, and it was very difficult to extubate him. And we did the CT for upper airway and showing tracheal web and bronchomalacia, clinical sepsis multiple times with positive culture, without positive cultures, urosepsis. So that is the story of baby of SA. Till now, the condition is very weird. The dysmorphic feature is more evident, and we are waiting for the WES. Next. So this is just to compare the problem list at admission and the problem list currently or updated one. Next. So I will wait here and again raise the possibility of mystery. When we have a baby, even if it's a rare condition, if it's difficult to diagnose, still we have a mystery. We need to solve it, because this solution, you have a family, they need to know about the prognosis. You need to modify his life in a way to give him the best chance. So mystery was solved actually by the WES or whole exome sequences. Next. It was diagnosed as SOPH syndrome. Next. It was novel pathogenic variant in NPAS, which is neuroblastoma gene. Next, Asma. When I go through this SOPH syndrome, actually it was my first time to hear about it when we got the diagnosis through whole exome sequences. And I found the cases which is mentioned, it's all, case report only, and it was the first time diagnosed in 2010. It is novel pathogenic variant in NPAS, autosomal recessive, and our baby was homozygous, and it is deletion in exon 45 to 48 on chromosome 2. So when we got a diagnosis, it is too much easier for the parents who were in denial state almost all the time to know we have a diagnosis, and this is explained by gene study. And what's his possibility? Actually, these babies, what was interesting in this case is they have long life. The first case mentioned in 2010, it was 27 years old when they found this novel gene. So they have long survival, and they have normal mentality. Next. So the mystery was solved. So what is this SOPH syndrome? As we mentioned, it was described in 2010 by Maximova et al. At the Yaktas population of Asia. It was studied initially in certain population in Asia. And it arises from biallelic pathogenic variant in NPAS gene. So this gene, actually, this deletion showing multiple phenotypes. So we have multiple phenotypes with underlying pathology. It's the same gene. The main characteristic, which is almost 100% of cases reported are already agreed on it, there is severe growth retardation. If it's not antenatally, it will be postnatal. And we will come to that. And they have senile facial appearance, skeletal anomalies in the form of small hand and feet, optic atrophy, and loss of visual acuity and color vision. And they have normal intelligence. That's very interesting. Next. So this SOPH, this abbreviation S for short stature, O for optic nerve atrophy, Pliger Wheat anomaly, which is PH. This is a special anomaly actually in the neutrophil. They have a special picture, which is the nucleus. It will be like a dumbbell shaped. And this is the four main criteria. The syndrome is named after that. And there is, as we mentioned, there is another comorbidities like hypogammaglobulinemia. Next. So S for short stature, severe postnatal growth restriction or retardation, senile faces, small hand and feet, optic atrophy with loss of visual acuity and color vision, and progress to optic atrophy, normal intelligence, and the Pliger Wheat anomaly in the blood. Next. So the genetist, you know how they are naming the syndromes. They always try to find a name, make it close to the clinical picture. So the genetist was suggesting, actually proposed by the name of Sophia, to consider immunodeficiency and acute liver failure. They are liable for recurrent attack of acute liver failure. Next. So again, as we mentioned, there is another sub-comorbidity included, which is combined immunodeficiency, diabetes mellitus, dwarfism, osteolytic lesion, whatever, skeletal anomalies. It can affect the limbs, can affect the vertebrae. Next. Dysmorphic feature, which is prescribed in case report mentioned regarding this SOPH syndrome, this palm brachydactyly and prominent fingers, single transverse palmar flexion crease, hypothenar pattern. The hypothenar eminence will be characteristic, wide foot and big halus, cylinder long bones and stenotic diaphyseal shaft and the flared metaphysis, cervical spines anomaly and widening of the spinal canal without affection of the neurons. CNS wise, it's functioning. There is widening of the spinal canal, but normal function, and osteolytic lesion. Next. The initial dysmorphic feature, which is applied to our baby, this is senile features. You give you impression of Progeria syndrome initially, triangular face shape, prominent eyes, bushy eyebrows, big prominent nose and pointing chin, and relative microcephaly. There is no microcephaly in fact, but relatively you feel it's big because the baby is not growing, and the body will remain small. This baby actually, he's now 5 months old, and he did not gain only 800 grams. to 800 grams since birth, and he's 5 months old now. So when you look at him, you feel he's having relative microcef, which is not real. Next. Next. These photos are a little bit interesting for one of the known case report, and they take like serial photo for the baby till the age of 6 years. So this is exactly how the baby looked when he was born, and this is the F and G. This is the age of school age, and this baby had this special X-ray finding. Next. Unfortunately, this table is very small, but I will share it with you. What we can tell, I can just explain it to you. It's very difficult to make it larger. You can hear me still?
Now you can.
Yeah. In this slide or in this table, we are seeing the whole cases which is reported in at the first time when it was diagnosed by in the YACTAS population, as we mentioned, Asian people. The study concludes 34 patients, and this is the finding which was there. Normal length at birth, almost 58% of cases. So they have the growth restriction after delivery, which 100%, like growth failure up to 100% in all cases postnatal. Craniofacial features almost ranging between 82 to 97. This feature we mentioned about it before. This is the facial asymmetry, small faces, senile faces, prominent orbit, hypertelorism, long philoceram, thin lip. This is ranging almost between 82 to 97% of cases. Skeletal anomalies also like ranging between 75 to 80 to 100% of cases. They have also skin lesions like senile skin and redundant skin. And one case actually it was linked to cutis laxa also. Synedactyly, palmar crease, sandal cheek, wide big toe. In the eye, which is the optic atrophy, it affects 100% of the cases reported in this study. Neurological finding, it was not that much, but normal intelligence it was 97% of cases, 34 cases. There was also involvement of the thyroid, which is affecting 8.8% of cases, and insulin-dependent diabetes affect almost 6% of the cases. Next. This also including some cases which their age ranging between almost 3 years to 27 years, and almost the same finding. All of them, they have postnatal growth restriction and dwarfism, and 100% optic atrophy, and the facial features was almost on and off, but more than 2/3 of the cases was positive, and normal intelligence in 100% of the cases. This is the case, very interesting case, and I'm happy that we got an answer finally. And this is my reference. So the message is, when we are discussing rare cases, we always think we may not face this case again. But I remember once we had a very rare case, and it was diagnosed with difficulty. And after 3 weeks, we had a case, similar case, and it was life-threatening condition. And because of the first case, which was diagnosed, we catch this case early, and we saved a life because of that. So even rare cases, when they are coming to a human being, it is interesting, and they deserve a diagnosis, they deserve a prognosis, and they deserve to tailor a lifetime plan for them because they have normal intelligence and long survival. Thank you. This is my reference. Any questions? I'm open for the discussion.
Thank you, Dr. Hayam, for your illustrative case discussion and step-by-step diagnosis till we reach finally to that one. Fortunately enough, we have sat with the parents many times. We updated them about the baby condition, and the parents believe that they need the baby.
Are we done? Thank you.
دكتور محمد صوتك بعيد شوي. تفضل دكتور محمد.
I'm just saying that thank you, Dr. Hayam, for your presentation and the step-by-step approach to till we reach the diagnosis.
I would like to thank Dr. Mohammed Abu Saif a special thank for his special dedication and support for this case. He went through the whole journey, and he has to deal with very difficult family because they have a denial stage. Yes, Dr. Ahmed.
اتفضل يا احمد علق يا احمد اتفضل.
Sorry, I can't hear you. Sorry for that. مش عارفه مش سامعه دكتور محمد. حد فيكم سامعه؟ تفتحوا لي مايك.
تفضل دكتور محمد. هي ممكن she's not hearing you. تفضل دكتور محمد.
Okay, so as we said that this case was too much complicated case, and we have to go through it step by step with help of multidisciplinary team of our guys from the genetist to start with the pulmonologist, because the baby had some issues about the lung, infectious disease, the baby had CMV, and finally we could reach the diagnosis. And we do face the parents, as Dr. Hayam mentioned, that we're in denial stage, but at the end they came to know what is the prognosis and what's the outcome. But what we do feel in this baby that he will hoping he can pass through all these things till we can send him home. The idea that this baby will have, he had MRI with some sort of brain atrophy, so all this could affect the intelligence later on, and this is maybe reported because most of the cases that have been described, all of them have normal intelligence. Okay, this is my comment, and the floor is open for any colleagues who want to comment on the case. Shukran.
Excuse me, I have a question.
Thank you, Dr. Muhammad.
Yes, I'm Dr. Sundos from Diba Hospital, pediatric consultant.
Yes,
First
Dr.
of all,
please
I want to thank
proceed.
Dr. Hayam for interesting case. But my question, according to the ROB and ophthalmologist consultation, why they start treatment as aggressive ROP, and it was no history of prolonged treatment on oxygenation or obvious no asphyxia.
See, this case, they did like a grand round on this case. 3 ophthalmology consultants, they reviewed the case and they decided to go for Avastin because there was a bleeding and there was nothing actually explaining that. And after that, the bleeding subsided, but there was he started in certain area pale of the optic disc and starting optic atrophy changes. But I think
Yes,
I'm not the one to answer it in details.
Okay, so thank you, Dr. Sundos, for your comment on this part especially. You know, this baby had been catched up with that SOPH syndrome, or what we call retinoproliferative disease. But after the case discussion, and when we came to know that this baby had CMV, so CMV can be implicated in the severe form of ROP. So we do feel that this baby had the CMV congenital type, which although we have done torch screening initially, and as you know, that torch screening only will show the antibody. At that time, the antibody was negative. But when the baby started to have thrombocytopenia and it is persistent, we have done this CMV and it came to be positive by PCR. So we attribute mostly the eye finding, which happened while the baby didn't have any finding or any predisposing factor due to oxygen therapy, because he stayed only minimal support, non-invasive oil. So this was the idea at that time. And as Dr. Hayam mentioned that our colleague from ophthalmology, they did round-table discussion with the head of department there, and the conclusion was that this really had some sort of retinoproliferative disease, which must be treated as ROB. So that's why they went and they gave the Avastin injection, and it is only once injection given, and the follow-up after that shows that there is some regression, but not that ideal one. Okay, this is, I hope it could answer your query.
Thank you very much.
Assalamu alaikum. Thank you, Dr. Hayam, for this interesting case. Dr. Harris from Diva Hospital. My question is about what is a hearing check for, what is the radiological finding of this baby? Because you said CMV positive, maybe, and he has all multi-system effect. What about the hearing check?
Hearing actually is planned on discharge. We are keeping for APR because it should be done in the other hospital, and unfortunately, the baby is stuck on ventilator for a while. So it is planned to be done on discharge.
Any more question for Dr. Hayam? Okay, so there is no more question. We can conclude the session, but I would like to thank Dr. Hayam and all my colleagues, because with today's presentation, Dr. Hayam, she kicked off the phase 2 of the tele-ICU, which had been decided earlier to start with the typical presentation, then we will go to the case presentation. And I believe most of our EHS facilities, they had an interesting cases. They can share with us their cases, and we can discuss it as has been done today with our case. So aiming, inshallah, and monthly, we will have at least one case presentation from one of EHS facilities based on the schedule. So thanks all, and with all your support and the guidance and help, the tele-ICU, alhamdulillah, showed a success. And later on, hopefully, we'll be able to do a grand round physically with virtually through the Teams or through whatever virtual system we have. Thanks all. Thank you. And have a nice day.
Thanks. Thank you all.
Thank you.
Thanks for attending.
We can conclude the meeting. Thank you so much. Assalamu alaikum.